Mrs. B, a 65-year-old black woman, presented to the emergency room with complaints of abdominal pain and nausea. She was admitted to a medical unit with a tentative diagnosis of small bowel obstruction. Admitting orders included instructions to notify the physician if the patient's nausea or vomiting increased. The nurse took report from the ER nurse and settled Mrs. B into her room. She informed her to call for her if she became nauseous, as she could give her some medication. Shortly thereafter, Mrs. B pushed her call button, and by the time the nurse arrived, Mrs. B had projective vomit all over the room and was experiencing some shortness of breath. The nurse called the physician and notified him of the situation. The nurse was to continue to monitor Mrs. B and notify him if the vomiting continued.
Oh, she's so sick?
The nurse was unaware of a second vomiting episode that evening because it occurred while a respiratory therapist was in the room, and he failed to inform the nurse. He thought he was being helpful by just assisting Mrs. B. The therapist failed to notify the nurse. At midnight, the night nurse on duty found the patient confused, her room smeared with feces, and her IV out. No vital signs were taken. The nurse cleaned up Mrs. B and the room, charted the episode, and did not report these findings to the physician, thinking that it was not unusual for an elderly woman to be confused when awakened in the middle of the night. Approximately 4 hours later, the patient developed coarse breath sounds and requested her asthma medication. Again, no vital signs were taken nor charted. When the night nurse returned with the medication, several minutes later, she found that the patient had vomited fecal material and had apparently aspirated, as she had no pulse or respirations. A code was called, but the team was unable to revive her.